Okay, hello everyone. Welcome to the Philosophy, Disability, and Social Change number 4. This is the second session, and our speaker today is C. Dalrymple-Fraser, and they are a postdoctoral fellow at the University of Toronto, just recently defended. Yay, congratulations. And if you'd like to know a little bit more about C, please read their interview in Dialogues on Disability. C's talk today is Counting Disability Stories. C?
Hi, everyone. Let me get slides up on the screen for us here. And if I can get a quick nod, Cecilia, that they're up on the screen. Thank you. So I'm C. Dalrymple-Fraser. I just defended yesterday, which means in part these slides are a little messier than I would hope. But in what I get through, I will explain anything that shows up. There's going to be a lot of text and some visuals. In terms of my own visuals, I'm a white non-binary person with facial hair and glasses sitting in front of a messy bookcase. I'm wearing a black dress shirt with some floral patterns on it as well. So as I move through, most visuals are decorative. Some are screenshots from policy reports, and I will explain the content of them as we go along. There will be cases where I have long quotes just to make sure that if the transcription doesn't get what I say, that you've got it on the screen as well. That said, the starting point for this presentation is part of what I've mentioned in that interview with Shelley most recently, and in the previous interview with her as well. I want to think about counting disability stories, and that's in part a project of thinking about how evidence has often worked in bioethics, or not. So my starting point is a lot of people want an evidence-based bioethics. That is, we want our moral arguments to be at least firmly footed on the ground some way or another. And a lot of the times this ends up looking like evidence-lined bioethics is the phrase I'm testing out. That we have arguments and that we find data that seems to fit it or evidence that seems to support it, and we put a nice little lining on our arguments. And I've wanted to start thinking about the different ways that we might count disability stories, or different kinds of counting disability stories. So that the title of this talk is deliberately vague because I want to think about a lot of different kinds of things here. By counting disability stories, we could mean, well, counting them, taking disability stories to matter. Or we could talk about counting them up. How do we accumulate all the stories that appear in the news, in our communities, in our networks? We could also talk about counting disability stories, that is, stories about counting disability or stories about counting disability stories. And I think all of these really messily fit together. That is, really what we count is going to impact what we count. And I mean that vaguely as well. The kinds of data we accumulate are going to affect the kinds of theories we develop, and that the theories that we subsequently test, the concepts and what we value is going to impact what we measure. And there's a lot really potentially to explore here. And I'd be really interested in exploring it. Today, I just want to ask a few questions about the counting and the stories that we tell about counting. This is an exploratory project. It's a new project. I've been tied up with defending a dissertation. This is taking the next few steps. I like using conferences as conferring, working together to tease things out. So I'm going to tease out a few stories about how disability data gets used in the context of Canada, where I work and live. So first, thinking about counting disability in Canada, whatever disability might be. The most recent evidence that we have from this comes from the Canadian Survey on Disability, which came out 13 days ago. So I haven't had tons of time to analyze it, but it's very similar to the past ones. So we can say a few cursory things. First, the Canadian Survey of Disability as a national project seeks to accumulate evidence and data about those whose, quote, everyday activities are limited because of a long-term condition or health-related problem, which as scholars of disability, we might already find as a bit interestingly narrow in some ways of what we're possibly couching as disability for measurement purposes. It's the survey is a primary data source. It builds on the national census data on those who seem to have concerns about activities of everyday living and asks them a series of further questions. I want to think generally about how this survey is conducted, first of all. So I have a few more points that are going to show up in this slide. First, it is predominantly an online survey. And there are some telephone follow-ups, but what we do is we look at the census data, we see who might count as disabled. We send them an invitation to an online survey, and I already want to think about who that excludes. Which disabled people are going to struggle most with completing activities that are primarily online, who have access, equitable access to internet? What kinds of groups are perhaps less likely to be able to participate in these kinds of modes without facilitation? What kinds of disability are we already excluding in our counting of disability? Explicitly, perhaps obviously given the format, but explicitly they say we're excluding communication disabilities because we don't yet have the tools for developing questions that accommodate here. And there's a host of others that they exclude. Importantly, because it's building on census data, the Canadian Survey on Disability explicitly excludes, and they say this, those who are living on First Nation reserves and those who are living in collective dwellings, not in standalone housing units with families. So this is things like hospitals, residences, group homes, rooming houses, and shelters, which are often spaces where disabled people live. The community spaces in particular, but also because we know that disability accrues disproportionately for Indigenous populations. People have been subjected to ongoing colonialism and genocide. What are we counting and who are we not? And perhaps unsurprising to anyone who knows Canadian data, I have to apologize. Someone has started jackhammering on the street. Hopefully it doesn't come through the audio. I'm seeing head shakes. Good. I can hear it. You don't have to. Of course, unsurprisingly, in the context of Canada, there is no direct racial or ethnicity data collected at all. Disability disavows, in many ways, a lot of the different kinds of things we might want to explore. And this becomes the primary source of disability information that is used as, quote, an evidence-based foundation for government analysis, policymakers, and program evaluation. Eventually, their plan will, I'm quoting from a source not on the slides here, lead to the production of detailed statistical information at the various levels of geography to highlight the experiences of specific population groups such as women, Indigenous people, racialized population, and those living with disabilities. Great, but there's this tendency to say will lead to a thing and when. The short version so far is that the Canadian Survey on Disability, what is it counting, if anything, is a very particular kind of disability. And that disability then comes to count in the ways that we develop policy. And it's interesting to think what's missing. One further illustration just with this survey. So here's one of the questions that they ask. And I'll put a second one on the screen momentarily. They say, do you have any difficulty hearing even when using a hearing aid as part of a qualification for what they call hearing-based disabilities? Similarly, a second question appears on the slide here. They say the following questions are about your ability to move around even when using an aid such as a cane. Only difficulties or long-term conditions that have lasted or are expecting to last for 6 months or more should be considered. Only consider aids that provide minimal support, such as a cane, walking stick, or crutches. I mean, my cane provides me a lot of support, but I'm asked even when I'm moving around with an aid like a cane, but only minimal. It's difficult, one, for me to figure out how to answer these questions. But secondly, who is this going to again exclude? If we're looking at who counts as disabled and things like quote unquote, the severity of disability, what kinds of framings of questions and things that are valued here are going to affect what we collect? What disabilities do we count and count? And the survey says, and there's a quote appearing at the bottom of your screen here, that the Canadian Survey on Disability is based on a social model of disability. It's motivating perhaps the framing of these questions as excluding from consideration those who do not have or who rely on different kinds of aids and accommodations to affect how they move around the world or how they hear or how they see and other questions. So it's based on a social model of disabilities. They say the premise is the disability is a result of the interaction between a person's functional limitations and barriers in the environment, including social physical barriers that make it harder to function day to day. And they ask questions about barriers a little later on. But do we discount people from being disabled because they are accommodated in their disability or having had found ways to navigate an increasingly inaccessible world? So all I want to do with this first survey is ask us, what disabilities are we counting and which ones are we counting? Because that's going to affect all sorts of things from policy development onwards. And of course, is the kind of data that bioethicists and philosophers are using when they're making reference to disability, that we can say, oh, between a quarter and a third of Canadians apparently have disabilities according to national data. How do we make use of that data and what are its limitations? This is important for a lot of ongoing discourses about medical assistance in dying in the context of Canada. So I'm not going to go into too many specifics about MAID. I want to think again about numbers, counting, and what matters. So I'm going to start by talking about medical assistance in dying in the context of Canada, which many people who read biopolitical philosophy will be well familiar with. And there's two prominent stories that we see around counting disability in MAID just before getting into the next few slides. The first is you'll see many proponents of MAID arguing that there's limited evidence that disabled people are disproportionately affected by MAID, and that the available evidence suggests that disability supports are available for those individuals. And so that many people who are in the media reporting that they're soliciting access to medical assistance in dying because they cannot afford housing, because it is faster to get on track for medical assistance in dying than it is to get Ontario Disability Support Program funding. Well, those are perhaps outliers. Those are not things that evidence supports. So let's ask questions again about the evidence and the stories that we might tell. So most recently, we've had the 4th annual report on medical assistance in dying in Canada 2022. It came out this year. It's about the data from the previous year. So that's why it's 2022. And to start, they talk about what are the eligibility criteria. So if you're not from Canada, here's a quick gloss. They say to be eligible for MAID, among other things, you have to first be diagnosed with a, quote, grievous and irremediable medical condition, where a person must meet all of the following criteria and some others. First, that they have a serious incurable illness, disease, or disability. These are not well defined. What the distinction is between them, we are not quite clear. Second, that they're in an advanced state of irreversible decline in capability, ability. And third, and this is a longer quote, experiencing enduring physical or psychological suffering that is caused by their illness, disease, or disability, or by the advanced state of decline in capability that is intolerable to them, that cannot be relieved under the conditions that they consider acceptable. Now, if this is the data that we're collecting about medical assistance in dying in Canada, and we're concerned about whether or not disabled people are disproportionately affected by it, we might think about the tensions between the ways that we count disability or the ways that disability counts. If eligibility is someone having a serious incurable illness, disease, or disability, however we're construing that, well, if we want to construe that in the Canadian national data way, we want to look at social context. But here we're focused on grievous, irremediable medical conditions absent those social factors. We're told that the suffering is caused by the illness, disease, or disability. But what does that mean on a social model more broadly? When we take for granted that disability is defined narrowly in a medical sense, in a biomedical sense, it seems to butt up against the different kinds of counting strategies that we have. On the next slide, I have another visual that people often reference from this report. It's got a lot of small text on it. I'm going to summarize it for us. So here's a chart from the report that summarizes the, quote, nature of suffering for those who receive medical assistance in dying based on practitioner reports that are submitted. And what it shows are bars on the right-hand side indicating what % of respondents indicated a certain kind of suffering. At the top, it says the loss of ability to engage in meaningful life activities. And this is 86.3%. Second, the loss of ability to perform activities of daily living, 81.9%. Inadequate pain control or concern, loss of dignity, inadequate control of symptoms other than pain. The list goes on, pointing out a few things here. First, loss of ability to engage in meaningful life activities. If we take it on the Canadian survey approach, how much of this is due to a disability in the sense of a biomedical condition, a grievous, irremediable medical condition, as opposed to social supports or broader accounts of disability with which we might be familiar? The loss of ability to perform activities of daily living may or may not be supported in certain ways, but both these top categories seem to count as ways that we count disability. Individuals who say that medical assistance in dying does not disproportionately affect disabled people really need to say what disability is, because on certain models that are commonly used in these kinds of counting, these are exactly disabled people. These are conditions of suffering that map onto the definitions of disability. Whether we want to accept those definitions, of course, I think we should be dubious. Our point is, how do we count and how do we count here? Other interesting things before we move on, because there's a lot of interesting stuff here, that nearly 1 in 5 people find isolation or loneliness to be one of the main causes of their suffering. Perceived burden on family, friends, or caregivers, which maps on to social scripts of disableism and ableist stigma. There's a lot to unpack. But what I want from these first few slides is for us to think about how disability is counted in the arguments that people make about medical assistance in dying and disability, and different ways that we could story these interactions, different ways that we could take these data to point to different things. A second main argument that comes up with disability and MAID concerns the availability of supports, that people are feeling either coerced to options or have supports available to them throughout the process, so they're not choosing to die because of an absence of support. And so Dying with Dignity Canada, which is a big pro-MAID foundation, has on their FAQ the following question. I've got a screenshot. I'll read it out for us as well. So on the state of palliative care, they say, here's a myth, their language. MAID is being provided at the expense of already limited palliative care resources. People are being compelled to choose an early death because of inadequate care. They say, here's the fact in response. Palliative care and medical assistance in dying both provide quality options for care at the end of life. According to Health Canada in 2022, 77.6% of MAID recipients had received palliative care. Of those who did not receive palliative care, 87.5% were reported to have had access to those services. So in response to an alleged myth that people are being compelled to choose because of inadequate care, we reference statistics about the availability of care. But availability and inadequacy can come apart. So let's go back to the actual MAID data. Here's a chart from the report. There's a lot on it. I know I've highlighted a few numbers for us because this is just a badly designed chart, among other things. They say, listen, the number of people who did not receive palliative care services is 2,573 in the last year alone. For those, if they wanted palliative care, it was accessible to 2,250 of them. On the right-hand side, they're talking about disability support services. They say persons who required but did not receive disability support services are 196. Disability support services were accessible if needed are 147. I'll do the quick math for you. You don't got to do it. That means in terms of palliative care services, at least 323 deaths happened for people who did not potentially have access to palliative care, ignoring the unknown few hundred variables that we've got. And at least 49 people died without access to disability support services. Now, this is all relying on practitioner reports as a data source. So there's a lot more to ask behind the scenes. But it's interesting when this gets reported by different kinds of organizations. When we have on the right-hand side here, I don't have it highlighted, we hear that 19.6% of people did not receive palliative care support services, and of those, 87.5% could receive it. This leaves still quite a few people who could not, potentially. If we only focus on percentages, it's a very small percent of people who did not possibly have access. But that percent also maps onto hundreds of lives or deaths. And so one way of thinking about how we count disability and disability counting stories is the kinds of numbers that we choose to communicate differently. A few other points on this report before starting to move to a wrap up. So here's another selection from that report in the same section. There's a lot of text on the screen. I'm just going to focus on what I've highlighted, which says the following. When we look at that palliative support available, the fact that all those people who didn't access it, that 87.5% could have had access to it, they say this result has been consistent from 2019 to 2022, suggesting that palliative care continues to remain both available and accessible to individuals who have received MAID. And if we think about different means of counting and what counts, we have to ask how many people, lives, or deaths before it does not seem available and accessible. When hundreds of people cannot access the support services they might want or desire. Is that on a national level enough to say that it's accessible, that it's available? And importantly, what is it that we have access to? Again, if you read biopolitical philosophy, if you read the news, you're going to know that a lot of people who feel compelled to choose MAID who are disabled are doing so not necessarily because of the inavailability of supports, even though they are, but also because of the inadequacy of them. Archie Rowland is a famous case of this sort, where someone said, I was fighting for better services, could not receive it. And so even though I was receiving forms of care, it was inadequate. And so having appeals to these kinds of data as answers to myths about inadequacy are not actually full answers. And more broadly, we might ask, how do single stories, those items in the news, sit against these accumulations of data and death? When we take aggregate data of these kinds and we map them across thousands of people and we point at small percentages, at what point do these start to matter for our argument? In the context of philosophy and bioethics, we often have evidence-lined bioethics that says if we want to show that MAID appears to be safe and working, whatever that might mean, look, these are only outlier cases. But how do we attend to these outlier cases? What matters and what counts? I'm just asking questions, right? So when we ask what counts and what counts, we might think of a few things. First, that our data are going to be shaped by the questions that we can ask, the questions that we do ask. If we're asking about the quality of available supports, these percentages are not going to answer them. If we're asking about the adequacy of supports, these are not going to answer them. If we're asking about whether disabled people are disproportionately affected by or choosing MAID, these are not going to be answered by many of the appeals to saying, well, these are outlier cases. What kinds of questions we ask are going to affect the answers that we get. And it's a valuable point for philosophers and others to interrogate those kinds of questions. But importantly, our questions are often shaped by the data that we have and can have. I'll say more about this on the coming slides. I've got a few quotes to wrap up this kind of presentation. But in general, I want to suggest that data is an important site for storying intervention in philosophy of disability. That just these two short case studies I've hoped to illustrate are ways of accumulating knowledge or evidence about disability in the context of Canada or disability in the context of medical assistance in dying. And yet they seem to miss a lot. But on the questions that we're asking in that data, they're not missing a lot because the questions themselves are framed in particular ways. And so it's worth investigating and interrogating how philosophy of disability, as interrogating the concepts that are founding these kinds of studies, might ask us to inquire differently, to count differently. Okay, so in the following few slides, I'm going to have a lot of text on the screen because I'm quoting people and I want to quote them directly. The first one is going to have mentions of suicide just because it's a book on suicide, but I want to take the point more broadly. I'm just giving you a heads up there. The first then is by Jack Douglas from the 60s, quite a while ago, in his Social Meanings of Suicide. He's investigating how sociologists count, measure, and theorize suicide. And at one point he says the following: most American sociologists who have done work on suicide have been oblivious of the need to even consider the formal meanings of the term suicide. They have generally assumed the meaning to be given, to be known by all. He says, this might seem surprising, but it's really not, the quote continues, when we look at the fact that the wedding of sociological theories of suicide to the official statistics on suicide has made sociologists quite dependent on the official reporters of statistics for their data, hence for their operational definitions of suicide. It'll do no good to make up a formal definition of suicide to be tested with data that operationally defined in some very different manner. That might sound quite technical, breaking it down for a quick moment. Listen, if we develop theories of disability and we want to talk about disability in the context of medical assistance in dying or the prevalence across the country, and if all that is available to us in primary data are biological, biomedical theories or weakly assessed social models, perhaps, that's going to make it very difficult at a policy level and at an evidence-informed level to rely on that evidence in support of theories that are not yet counted. And so one project for philosophy is setting up those different concepts that we could perhaps interrogate, not only the data that we have, but the data that we could develop. A similar argument, I think, more closely to the context of medical assistance in dying comes from Aliga Lafontaine. And so I'm going to read through what is a long quote here and then wrap up. So Liga LaFontaine in 2016 gave testimony to the Physician Assisted Dying Committee in Canada when they were trying to figure out some laws around MAID. And what's core to his testimony is what counts as medical assistance in dying versus what has come to be known as a regime of medical assistance in dying, capital letters. So this is going to take up the remainder of my time, but I'm going to read verbatim across a couple slides here because I think it's important to hear. LaFontaine says the following. When residential schools exposed children to nutritional deprivation and medical experimentation, that was medically assisted dying. When traditional medicines and cultural practices were made illegal, driving traditional healing underground, that was medically assisted dying. When traditional medicine is appropriated, depleted, and patented by private industries, so-called discoveries that have been known by indigenous peoples for generations, thereby removing access to our own ways of healing, that is medically assisted dying. When traditional medicine is treated with hostility by mainstream health professionals despite being requested specifically by patients, that is medically assisted dying. Apologies. When Child and Family Services apprehend Indigenous children at an alarming high rate, if not the highest rate of all demographics, with medical decisions made by the Crown and an inconsistent quality of standards that contribute to children dying and career going missing, that is medically assisted dying. When the trauma of residential schools is perpetuated intergenerationally, we do nothing to stem the tide of abuse, addiction, and suicide that overwhelms Indigenous communities through insufficient mental health intervention, except in crisis, that is medically assisted dying. When Indigenous peoples have programs designed without their input, then are chastised for poor engagement in mainstream healthcare, that is medically assisted dying. When Health Canada provides 40 programs that do not provide comprehensive primary healthcare on reserves and neglects to provide a seamless transition between federal and provincial health jurisdictions, that is medically assisted dying. When health systems prescribes benzodiazepines, opioid stimulants, and other prescription substances without considering the high risk of addiction and overdose, that is medically assisted dying. When health professionals request services for Indigenous patients at their requests are denied by bureaucrats at Health Canada who ignore clinical recommendations, that is medically assisted dying. When nursing stations employ health professionals that lack a skill set to provide emergency and urgent care, or when nursing stations lack basic life-saving equipment and medication that does not meet the minimum standard of every other health facility, that is medically assisted dying. When there is no monitoring, tracking, or enforcement of standard practice that every other Canadian can expect when receiving medical care, that is medically assisted dying. And if an Indigenous person dies and no one tracks it, does anyone care? What counts and what counts is a core question to ask. What LaFontaine is not just interrogating is what should we mean by medical assistance in dying? Your clinical practitioners and bioethicists will say, well, that's not what we mean by the phrase. Well, what things are we counting and what things are we counting? Again, the data that we have are shaped by the questions that we ask and can ask. Our questions are shaped by the data that we have and can have. And so these are sites for theoretical and storing intervention, including and through philosophy of disability. And there are a few steps in this direction. Wrapping up now. So you may have seen through the Disability Visibility Project, I have a screenshot on the right-hand side of a title of an article that says, perhaps they won't have died in vain, the GRIM project. GRIM is taken from grievous and irremediable medical condition from Medical Assistance in Dying. Catherine Frazee and Heidi Jans have been working to collect disabled stories about MAID, developing a counter archive to quantitative data. There are some concerns about this approach too, I want to indicate briefly. They say in this interview on the Disability Visibility Project that we have also heard from a few people who are interested in the project, but withdraw upon learning that our aim is to potentially gather evidence to dismantle MAID because they don't want to lose what they see as their only choice for getting out of their suffering. That is, in trying to accumulate stories to build a counter archive to quantitative data for individuals who don't want to lose what is currently available to them, they're withdrawing their stories. And so here, even as a counter project to existing data practices, this is an evidence-lined project, insofar as there's a goal in mind and evidence is being collected around it. We really need more opportunities to have open conversations about the different kinds of narratives, to build alternative kinds of archiving systems, to think about the different ways that we can tell stories about how we count. And other models exist as well for thinking about how we archive and accumulate information. The AIDS memorial quilt is a big instance of this, with each tile on the AIDS quilt being roughly the size of a burial plot. of humanizing individual deaths that were obscured by the quantitative data in the United States. But still, even at these levels of detail, when you abstract, if you zoom out on the interactive AIDS quilt online, the accumulation of data, the accumulation of stories can easily mask, again, different kinds of outliers. So we're at the end of time here. So all I want to say again is I think it's interesting to explore different kinds of counting disability stories. And I mean that in a few different ways, and that I indicated at the start of this presentation. And this is a question asking presentation. It's a conferring at a conference. But I want to illustrate that a lot of us are engaging with data, especially those trained in philosophy who haven't been engaging with data or trained in data. And it's worth asking how we can do so differently. And that's all I've wanted to do today. Thank you.
Thank you, Steve, for this wonderfully informative talk. So we have about 20 minutes for Q&A. If everyone would like to please go ahead and place your questions in the Q&A session. And I'm going to just wait for those to populate. So while we wait, I wanted to mention, I think it's Mitch Syria, but I'm not quite sure if that's how to pronounce their name. They noted the following during your talk. Also, the idea that palliative care is sufficient presumes the medical model. How is palliative care going to address things like ableist discrimination, stigma, forced joblessness, etc., that affect disabled people's quality of life?
I take that as a point of agreement. Is the
Yeah.
simple response to that comment.
Yeah. And then I also had a clarificatory question. So when you were showing us the data, the information on the data that they collect for MAID in Canada, I thought that you said that it was not necessarily taking into consideration social factors. And I'm thinking that meant social and economic factors, right? But I wasn't quite sure because when I looked at the data, I thought, well, some of this information seems to be social, right? So like questions about isolation or loneliness, I think that seems to be socially related, and especially also economically related. If you have the funds to be able to become mobile quite easily, right, then you'd be less likely to be lonely. But I wasn't sure if you were considering all these data points to be not social, or so this is my question for clarification.
Yes. I will point out that some people say they can't use the Q&A. If you want to type in the chat, if you're comfortable with that, that's fine. The hosts have also indicated that if you're a panelist, you can come on camera. And I also neglected to say what I usually do at the end of every presentation. I like thinking slowly. It's great if you do too. Feel free to ask your questions later in time than now if you want. Yeah, so to the point of clarification, what I had shown on the slide that I believe you're referring to is that chart of different kinds of suffering. Is that right, first? Yeah, so along, yes, so along those, it indicated things like, well, there are things like isolation and loneliness. There are things like perceived burden on families and others. And I do agree that these seem to be, among other things, social economic factors, things that are steeped in perhaps ableist structures of the ways that we relate to others, about what it means to be disabled and be a burden, and what different kinds of supports could be there. But MAID as a broader project for its eligibility is only focused technically on suffering that is caused by the disability. So what I'll do is I'll get my slides back up and I'll show this for illustration. If I can make everything work in our favor. In 3, 2, 1, we should be sharing the screen again. And I'm just going to zoom down here. It's going to move quickly. I apologize. They say a grievous irremediable medical condition, serious incurable disease or disability, advanced decline, and experiencing enduring physical or psychological suffering that is caused by their illness, disease, or disability, or by this advanced state and decline. And it's not obvious to me, and I take this to be part of the point of clarification, that some of these things on the following slide are necessarily caused by right? Disability, rather than the broader ableist or disableist structures of how we respond to, relate to, and frame things like disability. And so my point is agreement with you that a lot of these sources of suffering do not seem reducible to the kinds of suffering that they actually seem to want to measure or prioritize. That's interesting when people make appeals to these kinds of data, what kinds of disability they may or may not be picking out. And in particular, there are some who say, well, look, the top types of suffering, the most common are loss of ability to engage in meaningful activities or loss of ability to perform these certain ADL activities, activities of daily living, like washing oneself or feeding oneself. Well, these two are mediated by social factors, accommodation, support, and they can be inhibited, of course, because disability is huge and things are very difficult and we have a non-ideal society, etc. But a lot of the sources of suffering here are not strictly caused by disability, illness, or disease. Many of them are. It's hard, for example, to talk about inadequate pain control without thinking about how disability somaticizes in particular ways. But yeah, a lot of the kinds of suffering that we're talking about do not befit the kinds of models of disability that elsewhere appear in the legislation and the policies around medical assistance in dying. There's a rift between the desire to have a biomedical model and ignore the social surroundings of these notions of suffering at time. But really, I want to get again to what kinds of data are we accumulating? What kinds of counting are we doing? And here they seem to be butting up against each other. Does that help as a clarification?
Thank you.
Yes.
And then we have a question from Luana Adriano Araujo. I hope I didn't mess up your name too much. They said, this was so great. We had a change in the Brazilian gathering of populational data. From an official information that we were 23.9% of the total population, the indications are that we are now less than 3%. This has been used a lot to deny that we should have disability quota in the numbers. They are legally 5% of the total positions in the case of bigger companies. I wonder, what do you think about this counting as also a means to deny rights, as you mentioned in the case of not recognizing disability, in the case there are no tangible and present barriers?
Yes, first of all, I'm so sorry that that's happening. That's horrible. And that's exactly how these different strategies of accumulating and counting can work in policy and elsewhere against us and against others. Really, in the background of all this, how we count is going to affect what we get as results and what we value too. So in the Canadian context, I indicated some of these survey questions that they use, say things like, and also a lot of people are apologizing for typos. That's fine. It's all legible. It's great. Are saying, look, how well can you hear when you have your cochlear device or hearing aid? How well can you see with your your glasses or other supports? And do you count as disabled on that condition? And if we extend these supports as ways of saying, well, you do or do not count as disabled based on what supports are already available to you, we're going to see diminishing numbers of disabled people, depending on how we count. And that can do harm. And how we choose to count can work in that favor. And how we choose to count will depend on what we value. And if we disvalue disability, there can be ways of discounting disability in the kinds of projects you explain. And so it does seem like, yeah, this is a case where the ways that we count are premised on the ways that we disabled people count to others. And that reduction in numbers, I don't think is necessarily illustrative. So let me make two other references there, different examples that go off in a different directions. So one briefly about genocide. I was teaching a course, we were talking about ongoing colonialism and genocide, and I had a student ask, well, there aren't that many indigenous people dying, so is it really fair to still call it genocide? And there's a question about how long does genocide need to go on for before it doesn't count as genocide because you've killed enough people that there are fewer people to kill? Right. How long do we count disability in certain ways that we afford these services or discount disability over time for those who receive accommodations? On the Canadian model of counting right now, if more people receive accommodations, fewer people are disabled. And on some liberation projects, that seems desirable, right, in terms of how we want to use disability. But on policy national schema, that's a way of erasing disability from public lenses and from policy considerations. And so, yes, absolutely, strategies of counting can be ways of obscuring policies of accumulation can be ways of obscuring, but so too if we don't count. What does it mean that Canada doesn't count any racial information on its death data for COVID-19, for medical assistance in dying, for suicide, that all these projects are done incidentally outside of national projects? Some of that is changing, but we have obscured so much information over time as a result. I see other questions, so I'm going to cut my answer there. But Luana, absolutely. That's terrible. And I think that fits here as well.
Thank you. And our next question is from Julie Mabey. They ask, it seems to me that one problem with data and stories is that disabled people themselves don't always attribute their unhappiness to social context, but to their impairment, disability, or age. That is, they themselves are embedded in the dominant medicalized conception of disability. Do you see a way in which this might be addressed in how we think about counting and stories about disability?
Yeah, that's a big problem in a lot of ways. So on the minor end of things, there are so many conversations even within disabled spaces of, am I disabled enough? Do we count, faculty in philosophy departments who have severe arthritis as disabled? A lot of them won't. And that's going to affect how often we think about disability appearing or disappearing elsewhere. And when it comes to suffering, which is at the core of your question, well, a lot of them are going to attribute things to our bodies, our disabilities, our experiences, because either not many people who are disabled who don't have access to higher education are going to be thinking about different models of disability. They might desire different supports. They might struggle for them. But if we don't always have this language, it's hard for us to think outside of our experiences. How might we address that in some of this kind of counting practices? I think counter archiving is a really valuable way of doing this. The kinds of projects that we get through, biopolitical philosophy, through the Grimm Project, for accumulating stories in other ways, through podcasting, are important avenues for getting at the grit. Because one thing that numbers do, the quantitative does, is it doesn't tell the story. And so if we know that a lot of people are associating their suffering with their disability because of whatever their reason is, right? That because that's missing behind the numbers that we accrue and accumulate, that's going to help us put more pressure on the kinds of data that we get that confirm the medicalized conception. Because it could be that all those people in the chart fully understand their own suffering as socially caused, but the chart is not going to tell us that in the way that is framed in this report, because we're just looking at data and percentages. So the short answer to a more complex question is counter archiving. Building up different stories, sharing and accumulating evidence differently is an important step in that direction, I think.
Okay.
Thank you.
Thank you. And next we have Hel Kevorkian, and they ask, let's see, excellent talk, C, as always, asking better research questions, collecting better data is something Canada really lacks, and using clear, more consistent and inclusive concepts, terminology across policies would help address or avoid some of the issues you highlighted today. We also need better and more accessible disability, income, housing, employment, etc. support measures than the existing inadequate ones as you highlighted. Some other potential solutions come to mind, but all take a long time to implement. What are some practical next steps here to help in the short term until more long-term measures are gradually put in place?
The short question to a long, complicated, the short answer here is quite what I just said the moment before to the previous question, right? That these storying projects, counter archives, are things that we can build on right now. In academic communities, attending to different sources of evidence that have largely been discredited if they're not peer reviewed, etc., is an important avenue inwards. Attending to these stories in the news as stories worth engaging, attending to zine fairs, to podcasts, to counter knowledges that have been produced in spaces outside of academia that aren't always counted, are things that we can do now, even if lobbying for better governmental national policy around how we accumulate data is a long-term project. These kinds of counter evidence collecting have been really important for community-based research when there has been government neglect, such as among Indigenous people testing air quality because the government doesn't care to do it for them. These are smaller projects that we can do, in the very least as academics, is attending to the different kinds of evidence that we prioritize. And what else is there? I've got a bunch of poetry and fiction here. The premise of my dissertation, often in these kinds of counter narratives that are missing from our academic spaces. So the short question about practical next steps, thinking about the other evidence that's out there, finding it, sharing it. It already exists, right? Often.
Okay, thank you. And then our next question is from Amal Salman. Recently, I was very surprised to learn that in Europe, or at least in the Netherlands, doctors are allowed to issue a DNR, do not resuscitate order, where they inform emergency aid like ambulances and ERs not to resuscitate the patient if at any time they go into cardiac arrest or stop breathing. And they are allowed to do it even if the patient does not agree. The reason they give is that they know that the patient's state after resuscitation would be very bad to the point that their life would have too much suffering, but they decide that for the patient. There's obviously so many problems and layers of complexity with this, but I'm wondering how much counting affects this topic policy individual decisions. For example, they know what the patient's condition will be after potential resuscitation based on counting.
That is a great and very complex question. As always, everyone's throwing nice, easy questions into the chats today. Let me say a few things in that direction, because I think do not attempt CPR orders or DNRs are really important sites of investigation when it comes to disability in particular, especially in spaces where, yeah, a patient doesn't need to be consulted. Even when patients do technically need to be consulted, there's a lot of issues coming into play, but the gloss at a possible answer here, just to simplify, so there's a lot of questions I see in the chat as well. One thing that informs these kind of decisions about predictions of outcomes is going to be the data that we already have. And some of that data is going to be intuitions, importantly. But a lot of what disabled scholars have pointed out is that a lot of the biases and assumptions on the part of healthcare professionals is that disabled lives are disvaluable. And we see this actually cemented in medical language, like disability adjusted life years, as a way of counting what people lose when they become disabled. The name disability is right there. Studies show that people anticipate that acquiring disability is going to affect their life more than disabled people who acquire disabilities report themselves. And so part of having these policies informing, well, the outcome is going to be undesirable in these ways. And so we can initiate this order without necessarily engaging with these wishes or advanced requests really is premised on a lot of data that we already think is suspicious. And so accumulating counting in different ways, I think, is important for pressing back against these. And we saw this especially in COVID-19. It was well documented that even healthcare institutions were saying, hey, we'd like you to fill out a DNR because we would not prioritize you. And so this would save time. You might have seen those letters circulating on Twitter a few years ago. So yes, and absolutely. There's a lot to say about death data in particular across its different spectra. Celia, I see some questions in the chat. I don't know where our time is for them.
We have a few minutes. So I think we could get through at least one question and then we'll see about the other one. Okay.
Yeah.
So Elena Gother Memorial asks, the LaFontaine quotes was very striking. This might be slightly tangential, but have you seen anything about what counts as healthcare? A big difference between the examples of medical assistance in dying that LaFontaine gives and narratives around MAID is that the later counts as healthcare. What are some of the ways we are reshaping the understanding of care provision to make death a valid form of treatment?
That's a really interesting question, and I'm just going to riff on it because I haven't thought about it too closely, but I can share a few things that I think are valuable. So in terms of what counts as healthcare, in both senses of counting, I'm reading it there as well, right? When we look at studies in health geographies, critical health geographies that are mapping, for example, racial inequities and access to healthcare institutions, we are mapping healthcare institutions, right? We are mapping certain kinds of institutionalized healthcare that is perhaps provided by governments in whatever country you're currently living in. But of course, there are many kinds of community care and cultural knowledges and traditional medicines that are not counted under those auspices and which many disabled people rely on, right? The works of Leolakshmi Piepzna-Samarasina points out the different kinds of care work that happens in communities and the ways that we can move towards it. And those things don't appear in that kind of data. And so one question I have behind the scenes about MAID reporting on the access to disability supports, or what are those supports? They're notoriously vague about about it. But for the individuals who don't request those supports or don't need it, is that because our community care is already providing it? Where is that information? Definitely what counts as healthcare is going to affect many ways that we count healthcare. The very least of it in the context of MAID is going to be what supports are available. Someone else earlier in the chat pointed that out for palliative care, for example. And also what kinds of community care that count to us are not necessarily counted in the academical senses. I think that's a very provocative question. I'd be happy to explore it further. I think that's great. Thank you.
Great. And so we have about a minute. I think maybe we'll cut it there. We do have a lot more questions. If you would like, would it be okay for people to email you their questions if they have questions that are
Absolutely. I love talking about this stuff. I'll put my email in the webinar chat in a moment.
Beautiful. Thank you again, C. And again, congratulations on your defense.
Thank you.
So we'll call that a day. Thank you everyone for joining us, and we hope to see you for our next session.